Hello everyone, we are from Group C and welcome to our presentation video. This is a list of our group members. In this video, we will discuss a medical case of a disease and determine the correct diagnosis for the patient. In the given case, a 45-year-old man who works as a construction worker is known to have complaints of nausea, dry mouth, and pain from chewing food. The patient is a heavy smoker for 10 years. In the gingival region of these 45 and 46, a reddish ulcer is found with brittle appearance and bleeds easily. The teeth of the region are loose with poor oral hygiene. Before determining the diagnosis of the patient's disease, it is necessary to analyze what things can be at risk of causing complaints. In this case, the patient was known to be a heavy smoker for 10 years. Smoking addiction is explained by the fact that smoking delivers highly regulated quantities of the drug, nicotine, to the brain in a pleasant manner. However, high-frequency smoking habits can lead to development of cancer cell growth in the oral cavity, namely oral squamous cell carcinoma. The mechanism of smoking habits in the development of oral squamous cell carcinoma itself is divided into two pathways, mutagenic and immunomodulatory.
Heavy smoking has been linked to the tumor protein 53 gene alterations in lung, head, and neck cancers. This gene is a tumor suppressor and cell division regulator that prevents cells from abnormal expansions. Tobacco contains carcinogenic substances that cause mutation in the TP53 gene, resulting in the inactivations of the gene and loss of the p53 cellular mechanisms. This could lead to the evolution of clone populations of cells, which eventually results in the growth and development of the cancer cells.
Another carcinogenic pathway of tobacco content in cigarettes is through inhibition of various functions of the immune system. Malignancy of the oral cavity is associated with the decreased expression of IL-2 in both CD4+ and CD3+ T cells. Tobacco-related oral cancer is also connected with defective CD4+ and CD3+ T cells, and IL-4 promoter and IL-6 functional genetic polymorphisms. Tobacco also decreases the transcription rate of IL-4 gene. IL-4 is an anti-inflammatory cytokine which has an anti-tumor activity. Therefore, a decrease in the transcription rate of IL-4 gene will lead to decreasing anti-tumor effects as well as resulting in increased growth and development of cancer cells.
Oral squamous cell carcinoma is a malignant growth in squamous epithelial cells of the oral mucosa, usually presenting itself as erythroplakia or leukoplakia lesions that may be exophytic or ulcerated in the palate, gingiva, buccal mucosa, lower alveolar, and tongue. The lesions have firm borders and are usually indurated. Oral squamous cell carcinoma is the most common oral malignancy in the head and neck area with multifactorial causes. Several risk factors are suspected to be the cause of the oral squamous cell carcinoma, such as smoking and alcohol habits, prolonged inflammation, and viruses such as human papilloma virus.
In this case, the clinical examination of a nodule showed an esophageal or superficial fragile, cauliflower-like nodule located on the floor of the tongue and bleeds easily. Thus, the classical user with a rolled border, spontaneous bleeding, and tooth mobility that the patient experiences is a late or established presentation of oral squamous cell carcinoma.
Common symptoms of RSCC include tooth mobility. At a later stage, RSCC invades the alveolar bone. This is supported by the radiographic appearances that show alveolar bone resorption, accompanied by widening of the periodontal space and furcation involvement, causing tooth mobility. The patient experienced grade 3 mobility in relation to the 44, 45, and 46 region. This caused the patient to experience pain during mastication.
Cross-sectional imaging, such as radiographs, could provide crucial information regarding the diagnosis and management of the disease besides clinical examination. The radiographic imaging of oral squamous cell carcinoma has an ill-defined shape and non-corticated border with radiolucent internal structure, loss of lamina dura, widening of periodontal ligament, and destruction of bone surrounding the lesion can also be seen.
Oral squamous cell carcinoma can also be identified through histopathological observation. Based on Broders classification, it is considered grade 2 moderately differentiated, where there are 25 to 50% of atypical cells. Cell dysplasia is also present, which indicates abnormal cell growth and hyperchromation. Other histopathological findings that indicate oral squamous cell carcinoma is horn pearl appearance. And that marks the end of our explanation regarding the topic. Sorry if there are any mistake. Hope you enjoy it. Don't forget to stay safe and stay healthy. Thank you and goodbye.